Today, we're going to talk about the challenge of pandemics. We're not going to focus on the medical challenge. All of you who are participants in this webinar are well acquainted with the challenges that are represented in this time of a global pandemic. On the other hand, there's also a very real behavioral challenge that is confronted by many people, perhaps by all people in the medical community. We're not only dealing with people who are falling ill, we are dealing with entire populations who are being asked to change their behavior. And in many respects, this is the most extraordinary, wide-scale behavioral challenge, perhaps since the 1918 Spanish flu epidemic. Now, many people, many professionals in medicine are not necessarily familiar with behavioral science. Just as there is a medical science, there is a very real behavioral science. And it is relatively new. So I would like to take you through a brief history of modern behavioral science, and then take a look at how we can learn from it in order to help you as medical professionals face the challenges, the behavioral challenges that this pandemic brings across. So if we look at behavioral science in many respects began with economics. Now, economics itself is a relatively new academic domain. Really only began in the very late 18th century with thinkers like Adam Smith, and classical economics, as we know it today, is perhaps typified by people like John Stuart Mills. Classical economics hypothesizes that we make rational decisions, that we are, as the economists would say, examples of homo economicus, that when presented with a decision in which we can calculate what is our best return, we will take the choice that gives us the best return, inevitably. And that if we do not do that, it is because we have not sufficiently understood. However, as time went by, and as the 20th century went by, many economists realized that people do not necessarily make always rational decisions. Psychologists, at the same time, and psychiatrists began to take a look at the human decision-making process. And perhaps the most important of these before 1970 was B.F. Skinner. Skinner took a look at how we and other animals actually make decisions. And his conclusion was that our decision-making, in many respects, is a question of conditioning. That we are conditioned. If we learn, through experience, that a certain decision will bring us something favorable, then we will have a tendency to reproduce that decision. So therefore, if I'm a young child and I learn that if I do not put my raincoat on and go out in the rain, my mother will be very upset. She will make me feel bad. She will punish me. As such, throughout my life, I might have an ingrained, deep-seated need to put on my raincoat if it's raining. So there is both positive and negative operant conditioning. I learned that doing something will bring me pleasure. I continue doing it. I learned that something will bring me pain or discomfort. I stop doing it. So for Skinner, much of this was instinctual. Some of you will recognize the idea of Igor Pavlov, who did this kind of work with dogs, and effectively Skinner based a lot of his idea of operant conditioning on Pavlov. Now, in the 1970s and 1980s, things began to change in the domain of behavioral science. And in fact, central to that change were two psychologists, Daniel Kahneman and Amos Tversky. And Kahneman and Tversky started looking a little bit more closely, and they said, well, while it seems that some of our behavior is apparently a function of operant conditioning, much of it is far more complex than that all the same, which of course Skinner knew. But Kahneman and Tversky, while clearly understanding that we are not always rational, we are not examples of Homo economicus, started to take a look and say, can we categorize exactly how we are irrational? And as such, in the late 1970s and early 1980s, they began to come up with the idea that in reality, Skinnerian operant conditioning was an important basis of much of our behavior, but there was something far beyond that. That in reality, we have two distinct thinking systems. And this was quite revolutionary. What Kahneman and Tversky realized is that we have a decision-making system that works very quickly. This is a distinct advantage for animals such as ourselves. We can make snap decisions that very often are extremely usable and very favorable to us without having to think too much. So they called this quick thinking system, System 1. It's not reflex. Reflex is something that's innate in us. When we're hungry, we feel hunger, we want to have food. That's an inbred biological genetic response. System 1 can be the function of conditioning, but one way or the other, it is a method that we use to make very quick decisions. System 2, on the other hand, allows us to make far more complex decisions. So for instance, I'm quite sure that anybody listening to this webcast, if I were to say, what is 2 plus 2, you would immediately say 4. That is not innate. We have to be taught that. We're taught very young, but you don't need to engage System 2. System 1 can handle that. If, on the other hand, I were to ask any of you, what is 43 times 79? You would undoubtedly be able to do that in your head if you spent enough effort. For some of you, it would be very easy. For me, it's not. But given enough time, I could work it out in my head. But it certainly doesn't come automatically. That is an example of using System 2. Now, the really important element that came out of Kahneman and Tversky is that we hate to use System 2. Our brains are lazy. They would very much prefer using System 1. They would very much prefer making very, very quick judgments, even in cases that are quite complex. And as such, we therefore can start to understand better how people make decisions if we look at what are the kinds of shortcuts that System 1 actually uses. Because that's how System 1 works. System 1 doesn't reason, remember. That's for System 2. System 1 can potentially use these kind of operant conditioning elements that come from a Skinnerian process, but System 1 uses some very specific shortcuts to arrive at quick decisions without having to rationalize them. And Kahneman and Tversky discovered dozens of them. And these were the results of many, many direct experiments and trials. And they are fascinating. And I very strongly recommend to any of you the work of Kahneman and Tversky, notably Daniel Kahneman, since unfortunately Amos Tversky died rather young. But their opus of work allows us to investigate what those shortcuts are. And we're going to see that understanding those shortcuts allows us much better to influence patient behavior. So we're not going to look at these dozens of shortcuts. We will look at 3 that are absolutely crucial to our specific topic of patient management in pandemics. The first is a shortcut known as a heuristic. In behavioral terms, these are known as heuristics, not shortcuts. The first is the availability heuristic. And what does that say? It says that we actually assess the likelihood of something not on the basis of fact, but rather on how easy it is to imagine it. I find this fascinating. We'll look at an example. The second we'll look at is known as anchoring, that we are in fact very strongly influenced by other similar but even unrelated messages presented at the same time. And the third is loss aversion, or what is known in behavioral science circles as the endowment effect. What that says is we value more what we already have than what we might gain. So let's take a look. First, let's look at anchoring. If I were to say to a bunch of people, how much younger than 100 years old was Albert Einstein when he died, they would give me an estimate for Einstein's age at his death. Now, some might actually know how old he was when he died, but most will not know the exact age, and they will give me an estimate. If I were to say to the same group of people, how much older than 50 was Albert Einstein when he died, they would also give me an estimate. What I can tell you is I guarantee you the first group will give me a higher average estimate. Now, to a statistician, that makes no sense. A statistician assumes that in the case of incomplete information, there will be a normal distribution of estimates around a mean, an average, which is probably close to the truth. But a behavioral scientist knows that this is not the case because I am actually anchoring the two groups. Because the first group is anchored very high. They heard the number 100. And therefore, they're going to be thinking, I know he wasn't 100. How much younger was he? But they will automatically be thinking higher than the second group that heard 50. Actually, just to point out, in case you're interested, Albert Einstein was 76 years old when he died, which is exactly midpoint between the two, or roughly. But an interesting point here, even if I were to say to the two groups, I read a biography of Einstein, and on page 350, it talked about his death. How old do you think he was? And to another group, I were to say, I read a biography, and on page 12, it talked about his death. How old do you think he was? I'll guarantee you the first group will give me a much higher estimate. Clearly, the page numbers are totally unrelated to Einstein's age at the time of his death, but just hearing the numbers does the trick. And study after study and experiment after experiment demonstrates that. So that's anchoring. Now let's take a look at the availability heuristic. This is really groundbreaking. Classical economists always assumed that if somebody were to assess the probability of an outcome to a decision, that would be based on a rational analysis of the data and the information they have. But in fact, that's not how we assess probability. That's not even how statisticians assess probability when they're not working. Every human being assesses or has a tendency to assess probability in a very specific way. It is by determining how easy it is. So I've done this, this little experiment a number of times. If you ask people, what is the ratio of deaths caused by sharks as opposed to cows in the United States or any country? I just happen to have the data for the United States. If I were to say, how many people do you think are killed by sharks every year as opposed to how many people are killed by cows? Last time I ran that as an experiment, the proportion given on average was 8-to-1. 8 times more people killed by sharks than by cows. In reality, it's 1-to-20. In reality, for every person killed by a shark in the United States, 20 are killed by cows. They are stepped on by them, or I don't really know about cow deaths, which is part of the point, because you never hear about them. There are no films about cows. There's Jaws. There's all these images we've seen on television, in the movies, of people being killed by sharks. When someone is killed by a shark, it's in the news. When someone is killed by a cow, it is not in the news. What all that means is these images are easily available to us. It is so much easier for us to imagine being killed by a shark than by a cow that we dramatically overestimate the probability of it happening. Now, then we move to the endowment effect. And fear not, we will look at how all these things correspond to managing patient behavior in pandemics. So let's take a look at loss aversion, or the endowment effect. This was demonstrated by Kahneman and Tversky in a famous experiment that they carried out in the 1980s, I believe. They gave two groups of students They showed them a mug. And those mugs were available in the university bookshop for $6. Not that any of the students necessarily knew that, but they were $6 mugs. Now, according to economists, you would expect the value put on those mugs by the students to be between $5 and $7 in general. But here's the thing. Kahneman and Tversky gave the mugs to one group. They said, here's a present. You have these mugs. Now, how much would you sell them for? The other group was not given the mugs. The mugs were put in front of them, and they were told that they could buy them. And they were asked how much they would buy them for. Now, I confess my original undergraduate degree was in economics, and it was actually before the behavioral economics revolution. I can attest that every single economist on the planet at the time would normally have assumed that the answers from the two groups would be roughly identical. Why? Because economists assumed that everybody would place a value, otherwise they would know as utility, on the mugs, and whether they already own the mug or not makes no difference. From an economic perspective, it makes no difference. I have something, I sell it for a certain price, that price should be around the price I would buy it for, at least in that state. However, that's not at all what happened. The first group, the group who were given the mugs, on average would sell them for $5.25. The second group wouldn't buy them for more than $2.50. Just by saying this mug belongs to you, the value associated with the mug on the part of the students was more than double. That is an extraordinary and totally unexpected phenomenon. Now, let's keep those three important heuristics in mind. Remember, we said that these are exactly the kinds of things that System 1 uses. System 2 can get around them, but it takes a lot of effort. We prefer using System 1. So this idea of we have anchoring, we have the endowment effect, and we have so what about social behavior? What about social behavior? When we're talking about changing social behavior, we're talking about something even more difficult. Because here, social behavior is deeply rooted in us from three different sources. First of all, part of it is instinctual. We are social beings, and we are genetically inclined to interact with each other. It's part of what being human is. Secondly, social behavior is very subject to Skinnerian operant conditioning. Every different culture learns different social rituals. So for instance, in France, if a man meets a woman, he will kiss her on both cheeks. If a woman meets a woman, they will kiss on both cheeks. In Japan, people will bow to each other. They typically don't actually touch each other when they meet each other. It is very strange, initially, when a French person goes to Japan simply to bow to people, as it is very strange for Japanese people often, when they come to France, to actually kiss each other. This is the result of the kind of Skinnerian operant conditioning that we learn very, very young. And then lastly, each of us has personal drivers that determine our behavior. We have different levels of these different heuristics and different ways to use our System 2. However, fundamentally, social interactions are inevitably very strongly governed by System 1. They are very typical. We go through social interactions many, many times in the day, and we use System 1 to determine how we deal with them. As such, it is very difficult to modify social behavior because of this instinctual approach, because of the conditioning behind it, and because of our personal proclivities. However, we're being asked to do that. Here we are in time of pandemic, where we're being asked not to kiss each other on the cheek anymore, not to shake hands, not in many cases even to go out. So pandemics call for these changes in social behavior. And many physicians with whom we speak are being asked by their patients how should I deal with this? And clearly are having difficulties engaging in these differences in social behavior. And this can go both ways. Many patients, as we're seeing, are very hesitant to adopt the new social behavior that is being asked of them. And many other patients, on the other hand, for instance, who have ongoing chronic diseases, might be going too far and be afraid even to come in and see their physicians for regular important checkups, for testing, for prescription renewals. And as such, many physicians are telling us that this is a significant burden. And they're not quite sure how to deal with it, because in most medical schools, physicians are rarely trained in behavioral science. Often they have some psychology training, but very rarely in behavioral science, which again is a very new domain. Now, luckily, there is a whole approach to behavioral science known as nudging. And nudging principles can help to guide people towards the kind of behavior that is beneficial to them. Now, where does nudging come from? It comes from a book, a 2008 book published by Richard Thaler and Cass Sunstein called Nudge. I very strongly recommend it. I would point out that Daniel Kahneman won a Nobel Prize in 2002 for his work revolutionizing behavioral science. He was the first psychologist to win a Nobel Prize in economics. Richard Thaler was a close student of his, in fact, still is, they're colleagues more than anything else, but Thaler was strongly influenced by Kahneman and Tversky's work. Of course, Tversky would have won the Nobel Prize with Daniel Kahneman if he hadn't passed away. So Thaler was strongly influenced by them. And he, having gained an understanding of these heuristics that we talked about, then went a step further and said, okay, what can we do about it? What can we do in terms of public policy to help people make decisions that are beneficial to them? And so Thaler and Sunstein worked together to develop a series of techniques that build on the behavioral science revolution represented by Kahneman and Tversky in order to build these nudge techniques. Many of them are designed to activate exactly the kinds of system 1 heuristics that we've discussed. Here's a very simple example, and we'll look at this. One of the first things that was approached was organ donation. Thaler pointed out that since people are so lazy, since all of us are so lazy in using system 2, we prefer to use system 1. We prefer decisions that are easy to make. What is the easiest decision to make? It is a default. If you say to me, would you like, in the case of untimely death, to donate your organs, saying yes takes effort. I'm going to have to think about that. If you say to me, would you like not to donate your organs in the case of untimely death? Once again, saying yes takes effort. In the first case, the default is I'm going to opt in. I'm going to decide that, yes, I'm going to use this option. I'm going to donate my organs in the case of untimely death. And here we see Austria. In fact, I should say opt in. Opt out underneath Austria. I have to make a decision to opt out, whereas in Germany, it's the opposite. In Germany, I have to make the decision to opt in. I should say opt in. Now, what do we see? We see two countries with very, very similar cultures, the same language. However, in Austria, at least up until recently, there was a 99% organ donation rate, whereas in Germany, there was only a 12% organ donation rate. Why? Because Austria is an opt-out country. The default is yes, whereas the default in Germany is no. In reality, I think that's changed recently in Germany, as many countries have realized that this dramatically increases organ donation rates. So what are some other techniques? We've looked at things like defaults. We're using the laziness of system 2, but there's also things like social norming, framing, and attribution. All of these in reality, are techniques that are built on the kinds of heuristics that we've already seen. Let's take a look. We've talked about organ donation. Using defaults can be much, much broader than that. So for instance, if it is assumed that one way or the other, what you should do is this, then people will have a tendency to go along with that decision. What about framing? Now, in many respects, this is built on the anchoring heuristic that we saw before. But framing means, how do you present information? This was an experiment that was also carried out by Kahneman and Tversky. And I've replicated it at least 3 times with physicians. So 2 years ago at a conference of oncologists in Germany, I asked, before the conference, I had asked about 200 oncologists. I gave them a description of a fictional treatment for a certain type of cancer. It was a long description of a treatment that does not exist. And the question was, given all of this description, how would you recommend this treatment to a certain type of patient, okay, as opposed to standard treatment today? Now, the only difference was that for 100 of those physicians, the very last sentence said, the treatment has a 90% success rate. Actually, it was a 90% survival rate. For the other 100, the very last sentence said, the treatment has a 10% mortality rate. All the rest of the description was precisely the same. Physicians who saw that description described as having a 90% success rate were 3 times more likely to recommend it than those who saw the same description with a 10% mortality rate. Now, of course, every single one of those physicians, if asked, obviously knows that 90% survival is exactly the same thing as 10% mortality. What is the difference? The difference is the word survival as opposed to mortality. In many respects, I've anchored them in one direction by saying survival and in another direction by saying mortality. And certainly, we're dealing with people who are highly rational, and nevertheless, we are human. We are subject to anchoring and therefore subject to framing. The next technique is known as social norming. We talked about how important social behavior is, and many behavioral scientists have looked at the impact of social norms. Certainly Kahneman and Tversky, also people like Ayent, who really look at how much we are driven by wanting to conform to society, even if we consider ourselves nonconformists. If we demonstrate that people like you are doing this, this is what they consider to be the default, that's a very, very powerful inducement to changing behavior. In many respects, the efforts of anti-tobacco and smoking cessation carried out by many governments over the last 50 years really only started to become successful when it became uncool, if you will, to smoke, when people who smoked were looked down at instead of being looked up at. So for instance, if we can talk to patients in terms like this, many of my diabetic patients keep track of the food they eat to ensure they are monitoring their sugar levels. How are you doing? Are you running into difficulties? If so, let me help you. Instead of saying it's crucial to monitor your food and your glucose, because right from the start, we're establishing this as a norm. You as a physician know that many of your patients are doing this. And now you're asking this patient whether he or she wants to be part of that norm or not. You'd be amazed at how powerful that kind of discussion, that kind of language can be in helping to change behaviors. And then we have attribution or endowment. Remember we said, just saying to a student that a mug belonged to them more than doubled their value of it, the value they put on it. Well, likewise, if we talk about gains, health gains that the patient has already made, and that by not engaging in certain behavior, those gains might be lost, For many, many people, that's much more powerful than saying, you have to do this, or there will be this consequence in the future. So if you stop seeing your doctor and taking your treatment because of the current context, because of the pandemic, for instance, your health might degrade despite all the efforts you've made up until now. It will be a shame to lose some of that advance that you've already made. It can again have much more impact than simply pointing out the benefits of this type of behavior. So let's take a look at ways of communicating with patients about things, for instance, like social distancing. Now, a pure informative strategy. Let's consider a healthcare professional who talks to a patient and says, close contact is a vector for the virus. You should avoid leaving your home, and if you do come into contact with others, you should maintain a distance of at least 1 meter until further notice. This is good for you and everyone else. That is true. The information has been conveyed, and a perfectly rational human being, a Homo economicus, would undoubtedly change their behavior on that basis, and many people will. But what if we try to apply some of the things that we've learned? How might we put that differently? Convey the same information, but in a different way. How about people in your community have been joining in the effort to fight this virus? So here we're using social norming. We're establishing that others are doing this already. So people in your community have been joining in the effort to fight this virus by remaining at home and maintaining a distance of at least 1 meter with others. I'm sure I can count on you to do the same and help accelerate an end to this crisis. Every day we do that is another little victory. Fundamentally, the information being conveyed is the same. But not only have we used social norming, we've also introduced the idea of a default. I'm sure I can count on you. In other words, I, as a healthcare professional, am assuming you're going to do this. That's an example of setting a default. Every day we do that is another little victory. And here what we're doing is we're using the endowment effect, attribution, to say, together we've gotten this far. And if we all continue with this kind of behavior, which I'm counting on you to do, which I assume you do, then we won't lose the benefit that we've already gained. Now, as someone who carries out research in behavioral science, I can assure you that for the vast majority of patients, this second way of communicating exactly the same information will have much more impact for exactly the reasons that we've seen. My very last slide, of course, in many cases, and certainly in this case, in the case of a pandemic, this type of nudging and nudging techniques can really help, but often they're simply not enough. That many authorities have decided to introduce initiatives, legislation, announcements, and so on that actually restrict movements, and that in many cases can lead to resentment on the part of many patients. And we see that likewise, these questions are being asked of physicians. Now, do keep in mind at the same time, from a policy perspective, introducing these types of legislation and announcements help to set social norms. As an example, here in France, we have only this past week started lessening the confinement. And immediately upon going outside and going into stores and so on, I see that absolutely everyone is wearing a mask. And I have to confess, in the very beginning, the first day I went out, I forgot to bring a mask. I immediately felt uncomfortable. Why? To be transparent, I've already had COVID-19. I had no problem. I'm not really a danger of contracting it again, I think. But I felt very uncomfortable because clearly this had very rapidly become a new social norm. So nudge techniques can help. Understanding these biases, understanding these heuristics can help. And they can help physicians to respond to the types of questions and the support their patients need, to adhering to these kinds of health and safety measures, to develop good habits in preparation for a new normal, and likewise to help existing patients not neglect their non-epidemic related health. And very lastly, they can very much help with all of your patients, certainly your chronic patients. Don't forget, simply asking someone to take medication every day is a big behavioral change, even if it's just taking a pill every day. So using these types of techniques should provide you with tools, hopefully, that you'll be able to use to make your jobs easier and to help your patients gain great benefits.